So the pancreas is located in the abdomen. It's behind the stomach, okay, and the pancreas has a lot of functions in the body. So I'm going to talk about pancreatic islet cells in neuroendocrine tumours. And many of these neuroendocrine tumours secrete hormones in the stomach, and some of these hormones can be overexpressed, and patients may present with problems due to the excess amount of these hormones. So there can be excess amount of gastrin, excess amount of insulin, but also excess amount of other rarer hormones like vasoactive peptide, that's VIP, or glucagon as well. But sometimes the neuroendocrine tumour may not produce any hormone, and that's called a non-functioning pancreatic neuroendocrine tumour. Now, in the olden days, hyperparathyroidism could not be treated as well. Our surgical techniques have changed. Our biochemistry detection has changed, so we can detect primary hyperparathyroidism at a much earlier stage. We can also detect pituitary problems at a much earlier stage. So actually, a lot of patients with MEN1 are now having problems with the pancreatic side, because the parathyroid can be treated very well and the pituitary can be treated very well. So I think this is a very important topic to discuss. So the most common problem in the pancreas, which is a functioning neuroendocrine problem, is a gastrinoma. And we're looking at about a third of individuals having excess amount of gastrin production. In about 10% of individuals, they may have increased amount of insulin. There are a lot of individuals who may have non-functioning problems in the pancreas, and that can be up to 50 or even higher %. And then very rarely the pancreatic neuroendocrine tumours can produce excess amount of glucagon or vasoactive peptide. And I'm just going to go through the actual anatomy of the pancreas. So some of you may have heard that there's a pancreatic problem in the tail of the pancreas, or the head of the pancreas, or the neck of the pancreas, and you may not be aware of the different parts of the pancreas. So hopefully in this diagram I've illustrated the pancreas, which is located in the stomach. The part that's very close to the intestine, that's the small intestine, is the head of the pancreas. The part a little bit away from that is the body of the pancreas, and the part very far away from the small intestine, which is located here, is the tail of the pancreas. Okay? And the pancreas is very important because it produces a lot of enzymes which are involved in the absorption of fat, but it can also produce a lot of hormones that are important in life. And one of the hormones is insulin, which is important to try to maintain a very good balance of glucose in your blood system. Okay. So the topic I was given was whether to do surgery in patients with pancreatic problems, or whether not to do surgery in patients with neuroendocrine tumours of the pancreas. And there's a lot of considerations that we need to think about when we think about the long-term treatment. So we could think about trying to get in very early, trying to remove any problems with the pancreas to try to prevent any problems from increasing over time. But we always need to weigh up the problems that can occur if you don't have a pancreatic gland in the body. So if I was to remove all your pancreas, then you would need to be on insulin, because insulin is required to maintain those glucose levels in normal range. So if you didn't have insulin, then your glucose levels would be very high and you can become very unwell. A bit like patients who have type 1 diabetes, they lack insulin production. So if you have this for the rest of your life, you may need to take insulin injections for the rest of your life. That's if the whole of the pancreas is removed. If part of the pancreas was removed, then the rest of the pancreas would actually compensate and produce that insulin that's required. But removing the whole pancreas is a high-risk procedure, and these are not easy operations. You need a skilled pancreatic surgeon, and if you are to undergo a pancreatic procedure, you should do that in a centre that's very used to seeing patients with MEN1 and having pancreatic procedures done. So that's the whole debate. We're going to think about whether to operate or not to operate. So gastrinomas. So gastrinomas produce excess amount of gastrin. If patients have excess amount of gastrin, then they can present with problems such as diarrhea, because all those pancreatic enzymes are not working, and patients may present with stools that are fatty, so very difficult to float when you pass those stools. Patients with increased amount of gastrin can have peptic ulcers, and they can have a syndrome called Zollinger-Ellison syndrome. And this is where patients have a lot of peptic ulcers as well as increased amount of gastrin production. Typically, gastrinomas occur with primary hyperparathyroidism. And actually, interestingly, if you treat the primary hyperparathyroidism, then some of the gastric symptoms can actually get better. So there suggests a link between both of them. But frequently, they appear as very small lesions, but in MEN1 syndrome, there's multiple lesions that occur in the pancreas. And that is the whole issue with regards to whether to operate or whether not to operate. So usually gastrinomas will be slowly growing, but frequently they can go to other parts of the body. They can go to the lymph nodes, they may go to the liver as well. Onset is normally over the age of 30, and we can do a blood test for gastrin, and we can also do imaging techniques to see what part of the pancreas is affected. So sometimes we can do an MRI scan of the pancreas, a CT of the pancreas. Some of you may have had an endoscopic ultrasound. So that is an ultrasound that goes through the stomach into the small part of the intestine and can visualize the area that's affected in the pancreas much better than an MRI scan, or in a different way to the MRI scan. Some of you may have had a nuclear medicine scan called an octreotide scan or a gallium dotatate scan. So these are different ways to look at the receptors that are expressed in the pancreas. And those receptors are somatostatin receptors. And some of the treatments are treatments which are geared towards those somatostatin receptors. So somatostatin analogues, octreotide, lanreotide, sandostatin. Yeah? Okay. So what is the treatment? Well, up until about the end of the 1990s, most patients who had gastrinomas may have needed surgery because there was no effective medical therapy. But we now have drugs that can lower the gastrin levels. They're called proton pump inhibitors. You may have heard of omeprazole, lansoprazole, and they lower the gastrin levels and try to prevent the complications of high gastrin levels. Because the main complication that can occur if the gastrin level is very high is abnormalities in the wall of the area that's affected. And that can sometimes present as acute problems, which is called a perforation, where there may be a hole in the area that's affected. But that does not occur now as much because we have effective medical therapy with proton pump inhibitors. Ranitidine is another medication that can lower those gastrin levels down as well. And then we can think about surgery. But then when we're thinking of surgery, we need to think about, one, what we're going to do when that lesion is removed. Because in MEN1 syndrome, as you know, a lot of the pancreas can be affected, and there can be small nodules in the pancreas that we just cannot detect at this stage, which may get bigger over time. Certainly size is important. So if the area is greater than 4 centimetres in size, then there is a 25 to 40% chance that it may go to the liver. But if it's less than 2.5 centimetres, then actually survival at 15 years is 100% if it doesn't go to the liver. Okay? And the presence of lymph nodes does not adversely affect the actual duration of survival. So, there's a lot of debate about treating patients with pancreatic neuroendocrine tumours, treating patients with gastronomas, when to operate, when not to operate. But as a general consensus, most units will think about an operation if there is a well-localised single lesion, which is greater than 2 centimetres, which has not gone to the liver. Because if you remove that, then some of the symptoms may get better. Okay? But a lot of patients with MEN1 don't always present like that. So lots of patients with MEN1 may have multiple areas of the pancreas that are affected. And actually using good treatments such as medical therapy may be just as good as thinking about removing one part of the pancreas and then going back in and trying to remove the other. Because I've told you that having a pancreatic operation has risks attached to it. And also, if you remove all of the pancreas, then you would need to have insulin for the rest of your life. And there are complications of uncontrolled diabetes, which can be just as bad as having problems with a pancreatic neuroendocrine tumour. So actually, really, it's a detailed discussion with the patient and with the rest of the multidisciplinary team, which I'm going to show you later on, which is very important in the treatment of these complex neuroendocrine tumours. So sometimes, if the gastronoma is a bit more advanced, we can think of therapy like chemotherapy. Sometimes we can think of somatostatin analogues, because some of these neuroendocrine tumours have somatostatin receptors that can be amenable to those injection therapies, sandostatin, octreotide, lanreotide. In some cases, if there's an area of the liver that's well localised, we can think about a procedure called hepatic arterial embolization. So to actually zap a part of the area of the liver to prevent those tumour cells from getting larger. Okay. So that's gastronomas. Does anyone have any questions about gastronomas? Yeah. Okay. So insulinomas. So insulinomas tend to occur in about 10 to 20% of individuals with MEN1. If someone produces excess amount of insulin, then your blood sugar levels can go very low. Okay? And patients may present with feelings of dizziness, they may actually pass out, and at that time the sugar level is very low, and that's because excess amount of insulin is being produced by the pancreas where the neuroendocrine tumour is. And typically they occur after someone has had a fast, so hasn't eaten for a while, or if someone is exercising strenuously, because that's the time you're trying to utilise a lot of your glucose. And because patients' sugar levels are very low, they tend to eat a lot to try to maintain the sugar levels, and patients may present with weight gain. Okay? So, how do we test someone for an insulinoma? Well, some of you may have had this done, and it's called a 72-hour fast. So if I took a normal individual and I fasted them for 72 hours, actually the blood sugar level does not drop. And that's because the liver is producing glucose into the blood system. But if someone is producing too much insulin, then if you fast that individual for a period of time, the glucose levels goes down because the insulin is very raised. And that is a good test to see if someone has an insulinoma or not. Because a lot of my patients present with non-specific symptoms, and actually not everyone presents with dizziness or collapse. Sometimes weight gain may be the only presentation with a bit of tiredness. So actually trying to mimic a state where they're not eating can actually bring out the low glucose in that individual. And then once we have biochemical evidence of an insulinoma, we can then think about trying to localise that area of the pancreas. So patients can have MRI scans of the pancreas, CT scans of the pancreas, or the endoscopic ultrasound. And in some patients, we may want to do a test called a calcium stimulation test, where we inject a bit of calcium to try to release the insulin from the pancreas, and we will find that the area that's producing excess amount of insulin is actually the area where the insulinoma is. So treatment of an insulinoma, normally they're well localized, so we can remove them. In some cases, they may be multiple, and if that's the case, then we need to think about whether to do surgery or whether to think about medical therapy. And certainly from a medical therapy point of view, there are medications that reduce the production of insulin in the pancreas. Diazoxide is one of those medications. And somatostatin analogues, so your lanreotide, your octreotide, can lower the dose of insulin in your body. So that can be used in patients where we feel surgery may not be in their best interest. Okay. So we've gone through gastronomas, we've gone through insulinomas. Glucagonomas are very rare, but if they do occur, then patients can present with a skin rash, they can present with diabetes, they can present with weight loss, and the glucagon level is typically raised. In terms of treatment, a lot of these glucagonomas are in the tail of the pancreas. So do you remember the original diagrams on this side of the pancreas? And if that's the case, you can take the tail of the pancreas quite nicely away. The rest of the pancreas is still there producing the insulin, so you don't need to go onto insulin for diabetes complications. However, treatment may be difficult because up to 50 to 80% of individuals may have other areas of the body involved. And if that is the case, then we can think about using chemotherapy, somatostatin analogues, or the hepatic artery embolization. Okay? But again, these are very, very rare. Vipomas, even more rarer. They produce a hormone called vasoactive intestinal peptide. And if you have too much of this hormone, it's called VIP, then patients get a lot of diarrhea, and because they're having a lot of diarrhea, the potassium level goes down. And that's all because of increased amount of VIP, which you can measure in the blood system. So again, if it's located in the tail of the pancreas, you can think about surgery. If it's gone to other places, you can think of chemotherapy as well as somatostatin analogues. But you can also think of steroids as well. Steroids can reduce the level of vasoactive intestinal peptide as well as hepatic embolization. Now, I think neuroendocrine tumours are probably the most relevant for this talk and probably the most complex part of the pancreatic neuroendocrine tumours in terms of how we treat non-functioning neuroendocrine tumours. Because they're not producing any of the hormones, they tend to present in patients who are asymptomatic. So they don't have excess gastrin or insulin, so a lot of patients may not know they've got this. So they're picked up on routine scanning. So if we do routine scans of the pancreas, an MRI or CT, we may see an area of the pancreas which is a little bit enlarged compared to the normal pancreas. And really the goal of therapy is to reduce the effects of the neuroendocrine tumour and try to reduce the risk of it going to other places and balance that in the risks of the pancreatic surgery and the complications that can occur afterwards. So there's a lot of debate in the community amongst a lot of experts on when to intervene on patients with non-functioning neuroendocrine tumours. Certainly the research in this field is lacking because we haven't got proper randomised control studies over a long period of time. So lots of the studies are what we call weak studies, which means that the design of the studies may not always give the answer that we're trying to look for. Certainly small pancreatic tumours can be found very early on, and sometimes when you scan an individual you may not pick up those small subtle changes that may be there and may sort of appear later on in life. And there's lots of debate about whether to intervene in these small lesions or whether to watch and wait over time. So I've gone through this: the operative risk of major surgery of pancreatic surgery, diabetes requiring insulin, dumping syndrome can occur after pancreatic surgery. So if the bowel is affected and removed, or part of the bowel is removed, then the absorption of food can change. And when patients eat, then they may get abdominal pain due to the part of the bowel that is removed, or they may get symptoms of dizziness due to something which we call dumping syndrome. Sometimes glucose levels can go low as well. And the fatty stools I was talking about, the pancreatic enzymes are very important for the absorption of fat in the diet, and if you're lacking those enzymes, then the stools can be fatty, and also you may not absorb as much fat in the diet. But we need to think about if we do surgery, will that mean other areas of the pancreas may not be affected? And in MEN1, the natural pathology is that various areas of the pancreas will be affected, and there are multiple areas of the pancreas that are affected. So I think most centres would agree that if the lesion is greater than 2 centimetres and it hasn't gone anywhere else, let's say to the liver, and it's well localised, then you can remove it if it's amenable to removal. Some centres have even recommended at smaller areas, but there's a lot of debate over whether this actually changes things in the future. So again, I said evidence is very lacking in this field, and good long-term studies is probably what's required and will happen in the future. There are other ways to treat non-functioning pancreatic neuroendocrine tumours. We can think of somatostatin analogues. A lot of these neuroendocrine tumours still express somatostatin receptors, even though they're not producing excess amount of gastrin or insulin or glucagon. Sometimes we can think of chemotherapy. There are other forms of therapy, tyrosine kinase inhibitors, targeted radionucleotide therapy, which I'm going to talk about right at the end, and also hepatic embolization. Okay. Some drugs you may have heard of, sunitinib or everolimus, are two of the relatively newer medications being used for more advanced disease. So I didn't really show many studies in my talks today, but these are 2 studies I just want to highlight. The first study is the Promet study. So this is a study in patients with mid-gut neuroendocrine tumours. So these patients, the majority of them did not have MEN1 syndrome. And mid-gut means tumours that affect the small intestine, okay? So not pancreatic. But if we look at patients with mid-gut neuroendocrine tumours that had gone out of the mid-gut area, and if you look at functioning and non-functioning mid-gut tumours, patients were either given octreotide, which is the somatostatin analogue, 30 milligrams every monthly, or a placebo. Placebo means no pharmacological or drug treatment. Okay? And these patients were followed up over time. And what was found was that over time, so this is 0 to 90 months, and this is the proportion of patients without disease progression. So if you're closer to 1, that means your disease is not progressing. If you're more away from 1, it means your disease is progressing. So this line here is the placebo line. So lots of disease has progressed after 30 months, or at 30 months. But actually, patients who were given octreotide, the somatostatin analogue, at 30 months, at even 90 months, a lot of patients did not have disease progression. So that shows that somatostatin analogues can be used but this is for midgut neuroendocrine tumours. You can try to extrapolate that for other neuroendocrine tumours. Again, most of these patients had sporadic disease, not MEN1. But when you looked at patients who had functioning neuroendocrine tumours or non-functioning neuroendocrine tumours, actually the lines were pretty similar. So it works if you have a functioning or a non-functioning midgut neuroendocrine tumour. So that was the first trial, that's the Promet trial. There was another trial called the Clarinets trial. And this looked at patients with pancreatic neuroendocrine tumours. Again, they had gone out of the pancreas and they were considered inoperable. Patients were either given lanreotide, the somatostatin analogue, or placebo. Okay? And again, a similar pattern was seen. So this is the same type of graph. This is time over months. This is the number of patients with no progression of disease. So closer to 100 means the disease is not progressing, further away it is. And you can see the lanreotide group is this group, and they have less progression to disease as compared to the placebo group. Okay. So, what about screening for pancreatic neuroendocrine tumours? Well, probably we should think about annual screening for those hormones in the stomach, so the insulin, the gastrin, the other hormones which I've shown you. Imaging, so we can think about MRI scans of the pancreas, CTs of the pancreas, those endoscopic ultrasounds. And some of you have said you've had the gallium dotatate scan, so that's a bit like the octreotide scan, a little bit more sensitive, looking at which one of those receptors are expressing somatostatin, which could mean the somatostatin analogues may be effective. Okay. So I think the most important slide is this actually. In terms of our treatment approach, it's always patient-centered. So we need to, as you know, take views from our patients and actually think about what is the best form of treatment for our patients. And it's a multidisciplinary approach. So I'm sure a lot of you know who is involved in our multidisciplinary team, but we have endocrinologists, we have surgeons, we have radiologists, we have your general practitioner, we have nurse specialists, geneticists, oncologists and histopathologists. And really the question I was given is a very difficult question to answer. So whether to do surgery or not to do surgery, because everyone is different and everyone's disease is different as well. So I think a lot of this is trying to use the expertise of everyone in the multidisciplinary team as well as the patient and think about what the long-term treatment should be. But certainly if the disease is well localized and hasn't gone to the other areas like the liver and it's greater than 2 centimeters, then probably pancreatic surgery should be considered, or in these cases. Yeah. Good. So in summary, pancreatic neuroendocrine tumor is difficult to manage, can either be functioning or non-functioning, and a multidisciplinary team approach is required.